For those of you that already know me, I love talking about hormones. They're one of my favorite topics to talk about. It's what got me started in the functional medicine space a very long time ago, 20 plus years ago. Um, and so it's a topic near and dear to my heart, and you'll kind of see how passionate I can get about talking about it. But tonight we're going to talk about both male and female hormones. I think there's a lot of overlap with them. And I think we need to always be talking about both of them. So I will get started here with you guys. And then there we go. So, oh, that's a weird little tag there. Okay. So hormones 101, we're going to talk a little bit about what hormones are and which different types of hormones we have in our bodies. And I'll make some distinction between male hormones and female hormones and talk a little bit about what those all mean. And I'll direct you as to which ones affect men more and why and all of that as we go through the lecture. But basically, hormones are just chemical messengers. They regulate every single bodily function and every body system that we have. They play a role in everything. They affect our metabolism, our mood, our sexual health, our cognition, bone, muscle, blood vessels, the whole nine yards. So typically when we like to talk about hormones, we start talking about hormones and how they affect us during menopause or during andropause when men start losing their hormones. But hormones actually start very early on when we're just a little idea in mom's womb. We're already starting to make eggs, and those eggs are already starting to produce hormones. And so those eggs can be affected by all of the different things that we do. And when we talk about toxins being affected generationally, that's usually what we're talking about. So if a mom is pregnant with a female child before she realizes it, at a certain time, if she's already started to develop eggs, her eggs could be affected by different toxins that she had been exposed to. And even though the baby itself may not be exposed or have problems from that exposure, that's how her children may have problems down the road. And that's how we talk about generational things. Or if we think about things skipping a generation, that may be why we actually see that, simply because of all of those exposures and where they're coming from and when they're happening to us. So we have several hormones that we're going to talk about tonight. We're going to talk about the main ones. So we're going to talk about estrogen, progesterone, testosterone, and growth hormone primarily. So estrogen, there's a bucket of estrogens that we kind of say estrogen in general, but what we're actually talking about is three different forms of estrogen. So we're talking about estradiol, estriol, and estrone. And in some respects, a lot of these estrogens have similar benefits to each other, but they also can carry different risks with each other. So estradiol is the strongest hormone that's present before a woman goes into menopause. It's what controls our menstrual cycle. It's what prevents us from getting hot flashes. It allows us to get pregnant. But once we get pregnant, we make more of a hormone called estriol. And so that's the most prevalent hormone during pregnancy, but it's very small amount produced during menopause. It is known as your most protective estrogen. So it protects the breast, it protects the heart. And then we have estrone, which is known as the bad estrogen. We don't like to have a lot of estrone around, and we produce primarily estrone once estradiol and estriol decline during menopause, and it'll get replaced with estrone. And estrone is a very strong estrogen. And so when we talk about women being estrogen dominant, it could be any one of those three hormones that's causing us to be estrogen dominant. But oftentimes what we're most concerned about is when estrone is too dominant because it just is so powerful and strong. So estrogen is responsible for keeping our bones healthy and strong. It is really necessary for good cognitive function and neurological function. It's great for our skin, and it's very protective of the heart. So if you remember the WHI trial or the WHO trial that took place well over 15 years ago now, almost 20 years ago, I believe, the big concern was that estrogen was causing heart disease, and no woman should take it because it increases their risk for heart disease. Well, that study was very flawed, and it is now the most studied study ever. So the study design was flawed because they tried to give estrogen to women who had already had a heart attack, and they wanted to prove that by giving estrogen, we could reduce a secondary heart attack. But that's not actually what they saw. What they saw was that there was an increased risk in heart disease in that case. We had already known that for a very long time. We knew that if we gave women estrogen, especially oral, and they already had a heart attack, we would see an increased rate of a secondary heart attack in the first 5 years and an increased risk in blood clots. So we knew that to be true. But the pharmaceutical company who funded the study wanted to use estrogen as a preventative to heart disease. And that's what they were trying to prove in this study. And so it was a failed study because simply that. They also did an arm of the study where they looked at women getting what we call unopposed estrogen. So they gave women with a uterus estrogen to see if they were going to develop uterine cancer. Why they did this makes absolutely no sense, because we already knew that if we gave women estrogen without progesterone, they were going to develop endometrial cancer. So why we had to prove that for the 100th time, I have no idea. But that was one of the other things that they were trying to prove or disprove in that study. So estrogen is super important, especially in people with cognitive decline. So if we see people with Alzheimer's disease, dementia, MS, ALS, we really want to optimize that estrogen level for them because it's brain protective. It's what actually helps us heal and grow myelin, the protective coating over the nerves in the brain and the rest of the body. And so without that estrogen, that myelin can start to disappear and we can start to have a lot of cognitive issues. So it's really important to have estrogen. There is concern that estrogen can stimulate growth in the breast. And if it does so, it can increase the risk of cancer cells. It's not going to put cancer there if it's not already there. But if there are cancer cells there that are stimulated or they're estrogen-derived cells, by giving estrogen, we could speed up that cell replication, which could increase the risk of breast cancer. Some people will say, well, that's okay. It's there anyway, and I'm going to find it sooner than later if that happens. And some people are not comfortable with that idea at all. They don't want to stimulate anything. And that's really just more personal opinion at that point. So that is all things estrogen. Well, I should say this too. So men have a smaller amount of estrogen where women have a large amount of estrogen. Men actually need estrogen present for erectile function and good heart protection. We just don't want a lot of estrogen around for them. If they get too much estrogen around, then they develop man boobs and they become a little weepy, and we don't want to see that happen to them. But they do need some estrogen to protect the prostate and help with erectile function. And then there's progesterone, and progesterone is like nature's Xanax. It's very calming. It's very euphoric. It helps us get into a deep REM sleep and keeps us there. It's necessary to hold a baby in the uterus. If somebody has a progesterone deficiency during pregnancy, you'll oftentimes see them have several miscarriages. They'll lose multiple babies because the progesterone is what makes the lining of the uterus really nice and thick and plush and allows for the baby to implant into the uterus. So that is its main role. But after menopause, it's a more calming role. Now, you'll hear a lot of doctors say that progesterone is not necessary if you don't have a uterus, which I disagree with, because like all the other hormones, progesterone is responsible for every single cell in the body. It has a role in creating blood vessels, protecting the brain. It's good for our skin. It's good for our bladder. It helps us build bone. I mean, there's so many uses to it. It's not just a hormone that protects the lining of the uterus. So very necessary. And that's what helps us keep balance between estrogen and progesterone. If we only give estrogen, that's when we make somebody estrogen dominant. If we only give progesterone, that's okay, especially if they don't need the estrogen. There's no bad things that happen if we just give progesterone. But you do want those hormones to be well balanced. And then there's testosterone, which both men and women have. Obviously, that's what makes men and women different from one another. Men have a lot of testosterone. Women have a small amount of testosterone. as we age as women, testosterone tends to get lower and lower in most women, but in some women, once we reach menopause, testosterone will take the place of estrogen. And when it does that, that's when you'll start to see the hair growth on the face. Their bodies will change. Our demeanors will change a little bit. And for men, they reach andropause usually a little bit later than women do. So women go through menopause about age 52, give or take 2 years on either side, where men will start to lose testosterone around 50-ish and closer to like between that 50 and 60-year range. However, that being said, we are seeing younger and younger men having low testosterone levels. So for the first time in my history of working, I'm seeing 20 and 25-year-olds with testosterone levels of a 60 or 70-year-old man. And that should never happen, but it's happening. And a lot of it has to do with our environment and the exposure of estrogen and all the chemicals that we're being exposed to. So that can be a real problem as we get older. Testosterone is responsible for our libido, both for men and women. Although I will say if your estrogen and progesterone are not balanced, but you have a good testosterone level, many women still will not have a good libido. All the hormones have to be balanced for women to have that really nice, robust libido. It is good for our muscle mass. So it helps us build muscle mass. It helps with our metabolism. It helps us to stay lean. So we have more muscle, less fat. It helps us burn fat. It is responsible as well for cognitive function. And testosterone can convert to estrogen in both men and women. So in some cases where there's a risk of breast cancer and we don't want to use estrogen, we can give testosterone to help with that and convert to a little bit of estrogen for them without seeing an increased risk. We also know that women who have higher levels of testosterone have a lower risk of breast cancer. So having that testosterone optimized is really important and really helpful. It's also really good for energy. If we don't have enough testosterone, we tend to have more fatigue. We don't have that drive, that competitive edge, that desire to go out and conquer the world and do everything we want to do. So testosterone is very important, and it does that same thing for both men and women as well. And then there's growth hormone. So growth hormone peaks at age 20 and declines after that. So by the time we reach 50 or 60, there's very little, if any, growth hormone left. And if we want good tissue repair, good metabolism, great brain focus and concentration, we need to have some growth hormone there. It's also helpful for sleep. But again, one of the problems with growth hormone is if we're have any kind of cancer cells present, it's a growth hormone, it's a stimulant. So it can cause those cells to grow a little more rapidly, which can cause a little bit of an issue for people. So we are always cautious about using growth hormone if we don't know if somebody has cancer cells present or if they're at risk for it. Growth hormone is a little controversial to prescribe. In the US, you have to identify a primary growth hormone deficiency in order to prescribe commercially available growth hormone. So there are places that you can get growth hormone precursors from, where they just have your body help make extra growth hormone. And those are totally safe and legal to use and don't have to go through a lot of problems with it. But if we want to prescribe true growth hormone, there's a little bit more of a challenge behind doing that. So hormones fluctuate moment to moment, day to day for every person, man or woman. They are the key or the key that unlocks things for us. So if a chemical messenger like a hormone gets into a certain spot in the body, it needs to unlock that message so that that body can work properly on that signal. But again, they do cycle. So when people are concerned about having continuous dosing of hormones, that's not exactly what the body's used to having. The body likes to see that fluctuation. That's why women cycle. So in a menstrual cycle, in the beginning half of your cycle, so we count day 1 as the first day of bright red bleeding. That's what we call the beginning half of the cycle. your estrogen and progesterone are very, very low. And starting on about day 2 or 3, closer to day 3, you'll start to see estrogen slowly rise until ovulation happens, and then it will gradually fall again. You won't see really progesterone rise in that cycle until closer to day 8 or 9. And then it will peak at ovulation, which is going to happen sometime between day 12 and day 14. And then it's going to rapidly fall, or sorry, progesterone is going to stay high until you get your period, and then it's going to rapidly fall. So you kind of see this estrogen coming up and going down pretty fast, where progesterone comes up more gradually and then stays up and then drops off. And it's that drop off of the hormones that causes us to have a menstrual cycle. So depending on where we are in that cycle, and if we're testing hormones at different cycles, the hormone numbers could very well be different. Now, a normal menstrual cycle can run anywhere from 21 days to about 35 days. We consider that time frame normal. And when we count a hormone cycle, we count from the first day of bright red bleeding to the next day of bright red bleeding. And that's how long your cycles are. So when we ask someone, how long is your cycle? It's not the time that you actually bleed for, it's the time in between the cycle. So when we ask what your flow is like or your period is like, that's the time of your counting. So do you bleed for 2 days? Do you bleed for 4 days? Do you bleed for 7 days? And then we like to know like how heavy is the flow or how light, because that oftentimes tells us what's going on with the hormones as well. So when we talk about using hormones, and we'll talk a little bit this later too, there's a couple of different ways that we can use hormones. We can do them in a cyclic fashion, where we cycle them to mimic that natural cycle, give estrogen more heavily in the beginning half of the cycle, and either less or no hormone in the second half, and give progesterone only in the second half. Testosterone can be given anywhere because that really doesn't play a major role in the hormone cycle at all. And men's hormones, they don't cycle quite that much. They go more up and down on a regular basis, but they're not a big swing like that. But they do go up or down about every 12 to 48 hours. So we'll see a little rise, a little fall, a little rise, and a little fall. And that's pretty consistent for them. So hormone imbalances happen because of a lot of different reasons. Part of it's age, stress levels. The more stress we're under, the more our cycles will be off. And many women can attribute to this if they've gone through a stressful event. They've had a death in the family, their cycle may be off, or they might skip a period. That's pretty common because that's happening because of stress levels, especially if there's a lot of stress or a prolonged time of stress happening. What we know more recently is environmental things are playing a significant role in hormones. A lot of the estrogen-driven chemicals that we use are causing disruption in our hormone levels. We call them endocrine disruptors. So, for instance, we give a lot of hormones to our animals that produce dairy products these days. Those are estrogen disruptors, they're endocrine disruptors. And when we consume those, they disrupt our hormones. And part of that is the reason we see such young men having higher levels of estrogen. And then we see more young women developing their periods earlier, like 8 or 9 years old, sometimes as little as 7, because they've been exposed to so many of these environmental estrogens. A lot of the pesticides and herbicides that we use have these endocrine disruptors in them. Plastics have these endocrine disruptors in them, especially the soft plastics. So they're exposing us to estrogen at a quite young age. When kids are bottle fed as infants, if you're not using BPA-free bottles, we're exposing the babies to that estrogen from very young ages on. And that can cause a lot of issues for us. Chronic illness can disrupt the hormones. It's known if people have infections like Lyme or mold or parasite infections, things like that, that we will see the hormones tank at a lot younger age, especially with things like Lyme and mold. They will disrupt the endocrine system enough that we can see premature ovarian failure or premature testicular failure because of those infections themselves. Sometimes once the infection is gone, your body can bounce back and reproduce those hormones. but sometimes once it's gone, and we can't do anything to resolve that. There are different medications that people get for a variety of illnesses that can block the hormones as well. Things like tamoxifen that we use in breast cancer is a common one that actually blocks the estrogen from being made in the body. And there are a couple other medications that will do some of that too. Other toxins like heavy metals or chemicals, they can do that. And certainly chronic issues like autoimmune diseases or neurological conditions can also affect the way the hormones are made. So there's lots of different reasons why the hormones can get thrown off. So some of the common symptoms for hormone loss in in women are fatigue, low sex drive, mood swings, weight gain. And where you're gaining the weight tells us a lot about what hormone is a problem. So when women gain a lot of weight around the midsection, that tells us that there's an estrogen dominant issue. Too much estrogen, not enough progesterone to balance that. If you're having weight gain kind of all over, then we start to think more about growth hormone or testosterone deficiency, things like that. And when estrogen falls, that's when we're going to start to see the night sweats and the hot flashes. And normally it begins with a very light flushing. The first thing people will notice is when they're sleeping, covers on, covers off. They're sticking their leg outside the bed because they get a little too warm, then they're too cool, then they cover back up again. That's a really common way to start with them. Or you might feel a flushing that comes over you. And usually it's from the waist up with this flushing. It just feels like a whoosh that comes over you. You might actually see your skin turn a little red and be blanchy. Some women get them severe enough where they literally break out in a horrible sweat or they're soaking the bed at night. Those are pretty typical hot flashes once the estrogen starts to fall. Sleep is another one. So we will start losing progesterone about age 35, where estrogen stays pretty consistent until I'd say late 40s, 45 to 47 is where it's going to start for most women. You'll still you'll still get regular periods, but you're going to start to see some of those changes with the hot flashes. And usually when that occurs, it's right around your period. Where with the progesterone, losing that about age 35, we'll start to develop more anxiety. We'll have insomnia. We'll cry more easily. We'll feel a little bit more PMSy when that progesterone starts to decline. So that's usually a good indication that that's happening. When estrogen begins to fall, we're going to see more joint pain, oftentimes more muscle pain. Definitely that brain fog. If anybody's had a baby and they've had that pregnancy brain, you kind of develop some of that in postmenopause as well. We start to forget things like where's our keys? It's more difficult for us to learn quickly. We lose our words sometimes. We forget names. That kind of thing is happening. And your breasts that used to be nice and muscular and perky develop more fatty tissue. And so that's what causes our breasts to hang a little bit more, is that lack of estrogen. When women have a mammogram and they're told they have dense breasts, that's not a bad thing. That means they've got a good amount of estrogen. It just means that the mammogram can't see through that dense tissue because it was never designed to do that. It was designed to see through fatty tissue, not dense tissue. So it makes it a little harder for them to do imaging on you at that case. And when we have dense breasts, we should be doing either an ultrasound or a breast MRI to truly see through that tissue more efficiently and more effectively to make sure we're not missing anything. And then the lack of estrogen and progesterone and testosterone all can cause osteoporosis, but we tend to think more of that being an estrogen thing. It's actually progesterone and testosterone, when they fall, that we see an increased risk in osteoporosis. So balancing all of these hormones for bones is really important. Same thing for men. Men develop osteoporosis as well. And that can typically come from that lack of testosterone. And especially we're going to see that in these young men that have a testosterone level of 200 or 300 in their 20s. That's when they lay down the most bone. Between like 15 and 25 or 30 is where we lay down the most bone. So if we don't have good, robust hormones for men and women during that time, we're not going to produce that bone when we're younger. So we're going to see more bone loss when we're older. All right. So for men, the symptoms of hormonal imbalance are very similar. It's the fatigue, it's the low sex drive, moodiness, irritability. You'll cry a little bit more easily. We will see a lot of weight gain around the midsection for men as well when their testosterone falls. They'll sleep more commonly. They'll want to sleep more often, but yet they will still struggle with some sleep at night. We will for sure see more joint and muscle pain, some brain fog. Erectile dysfunction is very common. Premature ejaculation happens with men who don't have enough testosterone, or if they're making too much estrogen, we'll see that. We will see prostate issues as well. If their hormones are imbalanced, and enlarged prostate, more prostate symptoms. They will develop something called gynecomastia, where they develop man boobs if their estrogen is too high and they don't have enough testosterone, or if they're supplementing with testosterone and their testosterone is really high, but they're converting a little bit too much of that to estrogen, they will develop those man boobs. And then certainly we will see them with osteoporosis again as well. Um, so we talked a little bit about this, but I want to talk individually about some of the protectiveness of or and function of all of the hormones. So we talked a little bit about estrogen's protective parts, supporting the bones, really great for the brain. The skin is beautiful. Your hair is beautiful. As we lose estrogen, our hair becomes thinner, drier. We will lose some of it. And then we talked a little bit about this estradiol. That's the one that's most prevalent during our reproductive years. Estriol or E3 is your most protective, and then E1 is your estrone, which we don't want a lot of. And the more we have estrone circulating, the higher our risk is for heart attack. And then when we start to lose all of these, we have more bone loss, more fat gain, and we just don't feel so well. We're a little cranky. And then we talked a little bit here, about progesterone function. I'm just going to skip this because we just talked about that one. And then testosterone, we also talked about. I think the one thing we didn't cover, though, is the replacement for testosterone for women. So it is not FDA approved for us to give women testosterone. So when we do that, it is considered off-label. There's no commercially available form of testosterone to give to women like there is for men. But it is really important for women to supplement with testosterone if they are deficient, because it makes all the difference in the world in how we feel. Yeah. So I think that's all I have to say about testosterone. And then growth hormone, we talked a little bit about this as well, but really helpful for metabolism, for weight gain, increasing muscle mass, tissue repair, regeneration. That's what we will see when the growth hormone is declining. We'll see the opposite of those things. And when we get good amounts of growth hormone back in the body, we sleep better, we're not as hungry, we can lose weight without having to put in hours and hours and hours at the gym and kill ourselves. It is truly an anti-aging tool. We've been using it as an anti-aging tool for over 25 years, but it does come with a lot of that controversy because it's not FDA approved for anti-aging. It's only approved for true growth hormone deficiency. So there are commercially available products for this. They cost about $1,200 a month minimum, are only covered by your insurance if we can prove primary growth hormone deficiency. Usually they won't even do it if it's secondary, but sometimes we can get it covered if it's secondary. So then we have to use it off-label, get it from a compounding pharmacy, or use precursors to growth hormone to help your body make them. All of these hormones are also going to decline significantly in people who've had head trauma. So one thing I think we don't do a really good job about is talking to people about head trauma, especially the men. We don't talk to them about how many instances of head trauma they've had when we're talking about hormones. And we really should be, because for every increased incident they have with head trauma, that significantly increases their risk for hormonal deficiencies. And this could be a head trauma that happens when they were a kid and they were playing football. We see it a lot in our military. We call it blast trauma. So every time they get by a blast, that causes head trauma. The recurrent firing for people who shoot guns quite often, that sound alone, if they're doing it without protective gear, can cause a head trauma. And for people who repetitively shoot, that becomes additional head trauma after additional head trauma after additional head trauma. And those things can cause significant problems with anxiety and depression and OCD. And part of that is due to the loss of hormones, but there are other problems that happen with inflammation in the brain as well. And we just don't put enough emphasis on that happening for our men. And we don't think about it oftentimes for women either. The more head traumas women have had, the faster we're going to see their hormones decline. And that's going to be a big issue for them as well. So there are bioidentical hormone replacement therapy. They're different than what we're used to seeing for the last 20 plus years. So there's conventional and then there's bioidentical. And I'll talk about both of them a little bit individually, and then I'll compare the two. So bioidentical hormones are just that. They are bioidentical. They're made from plants. Typically, it's wild yam that they use, and they can make any hormone from a wild yam plant. And all they're doing is changing the molecular structure. So every single hormone has a different molecular structure to them. If you add a tag to the base molecule, it becomes a different hormone. If you take that away, it becomes a different hormone. So in the laboratory, they can do that to make a bioidentical hormone. And if I was to take a hormone that was bioidentically made and a hormone from your body, and we put them under the microscope and we looked at them, they would be identical. Nobody would be able to tell the difference between the two. And what's really good about that is the body can recognize that. And it's not trying to figure out what's this extra tag that's over here on this molecule that I don't recognize and I don't know what to do with, because it sees the exact structure that it's used to seeing, and it knows exactly what to do with all of it. So we do have FDA approved bioidentical hormones on the market. That's your patches and your oral estrogen. There is no bioidentical patch for progesterone. There's only an oral capsule, and it typically comes in two doses. It comes in 100 milligrams and 200 milligrams, and it's made in a peanut oil base. So as long as you don't have a peanut allergy, and I would argue that you don't have a mold allergy, because if you do, peanuts tend to be very moldy products, and there's no way they're going to get that mold off of all of the peanut oil that they use. The oral capsule can work pretty well, as long as your body fits into that dose of 100 milligrams or 200 milligrams. If it doesn't, and you need something in between, commercially, there's nothing else available. And that's when we have to get them then from the bioidentical or from the compounding pharmacy for the bioidentical hormones, because then we can have it made in whatever we want. We can have it made in a cream or a gel. We can't have it made in a patch yet at the bioidentical hormone or compounding pharmacy. And we can also have it made in any strength. So I can have it made literally in 0.25 milligrams all the way up to a 200 milligram dose in a particular form. Once it gets to the 200 milligram dose or beyond, then oftentimes we have to separate it because the molecule is very large, and we can't put more than that into a cream because it'll get cakey and it won't absorb well. And we can't put that much into a capsule because it won't absorb as well either. So then we have to usually split that dose up if it has to get higher than that. There is estrogen that comes in a patch, bioidentical estradiol, which is plant-based. These are things like your Vivel, your Estradot, things like that. The patch is a little bitty patch, depending on which one you get. Some of them are a little bit bigger. They look like a postage stamp. And they will deliver only estradiol, but they will deliver it very uniformly. And some women need that. They don't like that up and down of a cream. So when we apply a cream, it's good for about 12 hours, and then it starts to fall off. And most women, since they're used to their hormones going up and down like that, it doesn't really matter to them. But some women, they don't like that up and down. Their symptoms come back too quickly. But if we use a patch that you change you change it twice a week, the doses stay more consistent for a longer period of time. And some women like that better. And so it varies. There is a estradiol oral tablet that is natural, but we don't like to give estrogen orally because it has to go through the liver to break down, and it goes through a different processing, and then there's more problems that can happen as a result of that. So whenever we give estrogen, we like to give it in a topical form or an injectable form. Now you can give progesterone in an injectable form as well. It's just going to be a thicker oil, and it's going to be a little more uncomfortable to give, where estrogen is more like a water-based. It's much easier to give that way. The only problem with an injectable estrogen is you're only able to inject estradiol. So we're not able to give any of the other hormones. Now, we talked about the bad parts of estrone. And 25 years ago, when I started this, we used to give something called Triest, and it was a combination of estradiol, estriol, and estrone, because the belief was that we want to give back a little bit of all these hormones and create the balance. But that was before we knew the body created more estrone after menopause. And so we were giving women more of the bad hormone. And so probably about 20 years ago, we stopped giving estrone. And now we only give something called Biest, a combination of both estradiol and estriol. And in the last, I'd say 5 years, there's been some controversy and discussion around should we give estriol at all? Because estriol may be inflammatory, because it's the primary hormone during pregnancy, and it could cause a little bit more inflammation for women. I see biologically where that comes into play. But I will say I've been giving Biest for well over 20 plus years, and I've never seen a woman have inflammation from estriol. I think you still have the good protection on the breast side and the heart side. So I like to still give some estriol as that protective mechanism. And when we give Biest, we can give it in whatever fashion we want. So I could mix a 50-50 blend of estradiol and estriol. I can give a 60-40 blend. I can give an 80-20 blend. I can give a 70-30 blend. So we can really dial it in for the individual patient. And like progesterone, I can give a very small amount. I can give something as little as 0.15 of a milligram dose, all the way up to 100 milligrams if I wanted to. We would never give that much in estrogen, but typically the highest dose that we're going to give is maybe a 1.25, 1.5. On rare occasion, I've given women more than that. I've given them 3 or 4 milligrams, but usually if you have to give that much, there's something else that's going on, because we shouldn't have to replace that much hormone for somebody. There is FDA approved testosterone for men. It's in an injectable form, or it's in a topical form, they don't make a patch for testosterone. It's usually a gel or an injectable. And again, it's a synthetic form, actually. It's testosterone cypionate, which is considered a synthetic form of testosterone. It's a longer acting testosterone. So some guys like that and some guys don't. There's also something called testosterone ethionate that can be given by injection, which has a shorter half-life. Some people like that, especially if they're converting too much of that testosterone to estrogen. Then giving an ethionate version can help reduce that. And then there's also something we can use called Clomid or N-clomiphene that can help guys make testosterone on their own if they don't want to use testosterone or they don't tolerate testosterone very well. And for women, we don't have an FDA-approved testosterone. So it comes from the compounding pharmacy, and it's typically made in a cream. You can give it as an injection for women for longer acting, but it is a little bit thicker oil. Most women don't do that. They prefer not to do that. And I'll talk about pellets, but I'm going to talk about that at a little different place in the lecture here. So when we talk about bioidentical versus conventional HRT. So conventional HRT that our mothers and grandmothers were raised on comes from horse urine. So in that horse-based estrogen, there are 12 different types of estrogen. And remember, our bodies make 3. There's 12. And they're 10 times plus stronger than human estrogen. We have to remember when we use horse-based estrogens, that estrogen has to take care of a 1,200-pound mare. Thank God, as women, we don't weigh 1,200 pounds. That would be scary for most of us. So why would we give an estrogen that is meant for a horse at a higher dosage and a higher level, and all these estrogens that are foreign to our bodies? Um, and when they did the WHO trial, that's the form of estrogen that they actually used. They didn't use bioidentical estradiol or bioidentical anything else. They gave horse-based estrogen urines, or horse-based estrogens that come from horse urine. So that's part of the issue. Now we're always bashing conventional HRT and saying that's what causes the risk of breast cancer. But the literature actually shows something different. It doesn't necessarily do that. We actually know that women who are on HRT for 5 years and did not develop breast cancer or have heart disease, their risk actually declines the longer that they're on it. What makes the biggest problem is the starting and stopping of the estrogen. So if we're on it for a few years and then we decide, oh, maybe I should go off, and then the symptoms come back and maybe I should go back on, and they hop on and on and on and off and on and off like that. That's what actually is causing a lot more of those issues than the continuous use of the hormones themselves. Oh, let me go back. So, oh shoot. So we also want to talk a little bit here about, okay, I have to be going the wrong way here. Let me go this way. The HRT, the commercial dose of progesterone. So there is, we don't call it progesterone, we call it progestin if it's a synthetic form, and it's known as Depo-Provera. A lot of people will recognize that name as the birth control Depo-Provera, but they also make a form for women who have a lot of bleeding. And they can use Depo-Provera in some men for prostate issues. The problem, if you've ever known anybody who's been on the Depo-Provera shot, is weight gain. And that happens because of the type of progestin that's being used. And that's also the reason we have so many different forms of birth control on the market, is because the estrogen is consistent in birth control. What changes in every type of pill is the progestin. And the reason they're doing that is they're always trying to find a progestin that mimics natural progesterone and doesn't cause the side effects like the synthetics do. And if you go through enough birth control pills, usually you'll find one that a woman can tolerate. And it's not the estrogen in there, it's the progestin that we don't tolerate well. Okay. So the difference between bioidentical hormones versus the conventional HRT is their molecular structure. So in order to patent something, it cannot be like nature. That's why bioidentical hormones are not patentable. And while many of them are not FDA approved, because they have to put it in some type of different delivery system to make it different enough from its natural source to hold a patent on it. So conventional hormones, remember the molecule, everything starts with a molecule, and each molecule of the hormone looks a little different. Well, when they're commercially making a hormone, they change the tag on that molecule so it's not recognizable by the body as that particular hormone. And now it is no longer like nature, and they can put a patent on it. And that's how we can have a commercially available FDA approved drug. So because of that change, it doesn't match what is in nature. It doesn't match what the body is known to use. And that's how we get side effects. With bioidentical hormones, there is a much lower risk of complications with it compared to the conventional version, simply because of the delivery system and how they manufacture it and how it's made. And it can be made as a patch, a gel, an injectable, or an oral. Orals are not tailored as well. And again, estrogen, we don't want to give orally. Progesterone, we can. Testosterone, we don't give orally either, because when you swallow the testosterone, it has to go through the liver, and then it can increase our risk for heart disease and high cholesterol and things like that. So we never want to give that one orally as well. So our favorite versions are gels or creams or injectables because we can adjust the dosages a lot easier. We talked a little bit about cycling hormones. When your hormones cycle naturally, your body is much more inclined to know what to do with that. It preserves the receptor sensitivity. So every part of our body has a little receptor that utilizes the hormone. So if you think of a little molecule, it's got this little tag that sticks up. It's holding its hand up and saying, hey, come give me estrogen. This one's over here saying, hey, give me progesterone. And so when we give hormones consistently in really high doses, those receptors start to become dampened and they quiet down and they're no longer looking for the hormones. And so what ends up happening is we have to keep increasing the dose of all of those hormones for the body to be able to utilize them again. And this is one of the reasons that I am not a fan of using hormone pellets. Because in order for the pellets to work, we have to overshoot the dose because they're put in your body for a 10 to 12-week cycle. So we have to put enough hormone in to last. The other reason I don't like hormones in pellets is their philosophy is to basically give women enough testosterone to make them a man. And I don't think that's a good thing. So when you're given pellet therapy, their goal for reaching progesterone levels on a woman is between 250 and 350. Now, remember, I said we're concerned with young men having a testosterone level between 200 and 300, because ideally they should be 600 to 800. If they're 18 to 25, they should be closer to 1200. So why would I want a woman to have the same level of testosterone that a man has when he's 60? That it doesn't make any sense, because naturally a woman's testosterone level is between about 15 and 55, depending on which lab you're using. So if you're supposed to be in that window of 15 to 55, why am I trying to push you into 250 to 350 range? To me, we're creating transgenderism when we're doing that with women. And women will feel amazing for probably the first 3 to 6 months on that high level of testosterone. They'll have lots of energy. They'll lose weight. They'll build muscle better. They'll have a great sex drive until they don't. And then once that hormone is in their body for a long enough period of time at that level, they're going to start to have problems with hair loss, irritability, moodiness, acne, oily skin, and they're really not going to feel great about it. And the unfortunate part is once that pellet's inserted, because there's a small surgical procedure that happens there to put the pellet in, once it's there, we can't take it out. It has to just ride itself out over time. And depending on how your body metabolizes those hormones, it could be slower or faster, but you have to deal with the side effects of that. And many pellet practitioners will tell you that when you develop those side effects, it's not their problem. Their goal and their role is to balance your hormones to the optimization that they were taught with the pellet therapy. They're not going to help you manage your hair loss. You can go see the dermatologist for that. But they're the ones that are creating the hair loss because of the high level of testosterone that you're being given by them, but they don't want to manage the side effects. And so I have a real problem with that. If I'm giving you a hormone and what I'm giving you creates a side effect, it's my responsibility to address what I gave you to reduce the side effects. And to just not take responsibility for that, I have a real concern with that. And I don't think that's good medicine. So those are just a couple of reasons why I don't like pellets. And I don't think a woman should have to go through a surgical procedure every 12 weeks, although it be minor, to shoot a pellet in their ass so that they can have hormones when they can put a cream on their skin or do a small insulin injectable needle a couple of times a week to manage their hormones. And we have much better control over the dosing when we do that. So if I overdose or I underdose, we can have you just take a little more, take a little less, inject a little bit more, inject a little bit less. And within a couple of days, those side effects are gone. So it's much more flexibility there. So When we talk about diet for hormones, it is really important for a good, healthy diet as we're managing our hormones. Having whole food nutrition, not doing a lot of processed foods, because a lot of processed foods have a lot of hormones in them because of how they're grown, all the pesticides and herbicides and chemicals that we put on them, and all the other adulterated things that we do to our food. So the more whole food we can eat, the better we're going to feel and the better our hormone levels are going to be. I also think it's really important for us to eat protein in the beginning part of our day. So whenever breakfast is considered breakfast for you, so if you're an intermittent fasting person and you're not eating breakfast technically until between 11 and 1 o'clock, you still want there to be protein at that first meal of the day. And then you want really good, balanced, cruciferous vegetables because that's going to help you pull out your bad estrogen and make sure you're processing that well. It'll help with the metabolism of estrogen. It'll help you control your weight better if you have a good amount of protein there. And then you want to have your healthy fats. So avocados, fish, avoid sugar. Sugar is going to spike hot flashes. Alcohol is going to trigger hot flashes. Stress is going to trigger hot flashes. So all the things that make us feel better during stress are going to trigger those hot flashes. So just know that as you're going through menopause. Why do I always have that hot flash when I have that glass of wine? It's the alcohol that's triggering it. So healthy diet as much as you can. And then I really believe in best practices. One of the problems that I have with people too that do hormones is they don't test. They assume every woman over a certain age is going to be deficient in every hormone. Therefore, I don't need to test. And that's what we believe in the conventional medicine world, is that I can put a woman on estrogen and progesterone and I don't need to test her ever to see what her levels are doing. But I have to test a man all the time. And I think there's something wrong with that because I have tested well over 10,000 women in my practice over the years that I've practiced more than once. And there are times when I'm surprised, like a woman tells me her story and I'm pretty good at determining like what's going to be deficient and where do we need to start without looking at the blood test. But there's always that unique woman that comes along that fools us. And we think she's got plenty of a certain hormone and she doesn't. Or I think she's going to be deficient in estrogen and her estrogen is fine and her progesterone and testosterone are not, or vice versa. Or they're really young and they present like what we call PCOS, where they have too much testosterone and they've been diagnosed with that. And I check their labs and they don't have enough testosterone. So sometimes these symptoms mimic each other and they overlap with each other. And they can be a little confusing. So I really think it's important for us to test and get a baseline and know what they are. In an ideal world, we would all have a baseline of hormones, both men and women, at about age 20 when our hormones are peaking, so that we knew as we aged, are we declining? And what was I dominant with when I was younger? So there are very specific body types that you can tell a person's estrogen and testosterone level by. So women with that real voluptuous hourglass figure, a little larger breast, little larger hip, they're very estrogen heavy when they're young. That's what allowed them to have that hourglass figure and produce the larger breast tissue. Women that are more straight, up and down, flatter chest, they tend to have more testosterone when they're younger. So when their testosterone falls, they're going to be more symptomatic from that versus their estrogen. Versus the woman that has the hourglass figure, when her estrogen falls, she's going to notice that. But if her testosterone's down a little bit, she may not notice a big symptom change with that. And that's simply because of how she's been. We also know that once a woman or a man reaches andropause or menopause, they will see a declining, more significant decline in their thyroid hormones. So you want to be checking your thyroid hormones on an annual basis after menopause or andropause to keep a good track on that, to see if those hormones are starting to decline, because all these hormones help each other. And if one's off, it tends to be all of them are off. And if growth hormone is off, everything's really going to be off then. So it's really important for that. It's also important for us to check our cholesterol levels because all of these hormones are made by cholesterol. And so when we're suppressing cholesterol as we get older, because we're concerned about heart disease, which is a lie anyway, over time, you will see these hormones decline more, especially in men, because they need all that cholesterol to make their testosterone. Women need all their cholesterol to make all of their hormones. So it's incredibly important to be measuring these cholesterol levels. And if people are taking a statin, the last thing you want to do is have your testosterone, or I'm sorry, have your cholesterol level be below 100, which a lot of these cardiologists are shooting for. Because if your cholesterol is less than 100, you're not making any hormones at that point. You've become basically a castrated asexual being. So you can't make the hormones because that's where they're made from, is cholesterol in the first place. And you're going to have a lot more cognitive decline when you don't have cholesterol as well. So I really think that measuring hormones is important, looking at tracking your symptoms. And then genetic testing can be very important for us to look at, how are you metabolizing these hormones? Do you metabolize estrogen properly? Or do you have a pathway that's blocked and you're not going to metabolize that? Having that genetic makeup and knowing that can be helpful as well with what we're prescribing. So in the future of hormones, precision is key, testing is key, and that's becoming more and more prevalent, especially in the functional medicine world, not so much in the conventional medicine world. But we have wearables these days, right? We have the Oura Ring, we have the app on our phone or our watch that tracks our menstrual cycle, that tracks our body temperature. So those wearables are going to, in the future, be able to tell us what's happening with our hormones a little bit more. Certainly genetics or genomics is another one. As we learn more about genetics, we will uncover more things that are affected by hormones and vice versa. And then I really think micro dosing and very tissue specific dosing is important for us. It's not about overdosing a woman. It's about giving the woman exactly what she needs. We know exactly how much estrogen and progesterone and testosterone a body makes in a day between a man and a woman. And when we're young enough, I don't think we should be replacing more than what the body makes in a day. Because when we do that, we're telling the body not to make any more hormones. And if we shut that whole process off, it becomes harder for us to wake up the body to make the hormones. It's one thing when we're postmenopausal or we have andropause and we're not making hormones at all for whatever reason. Sometimes there's a medical reason we're not doing that. Then you can replace everything that's made in a day and maybe a little bit more. But otherwise, we shouldn't be trying to do that. And if your hormones are well balanced and you still have those symptoms that you came in with that were thought to be hormone driven, then we have to look at some other reason or the other cause that's causing those symptoms, because it's not always just hormones. It would really be nice to get a bioidentical transdermal patch. That would be great for hormones, but we don't have that available yet. We only have an estradiol patch. And I think AI personalization is going to happen. We're going to see more AI come into the mixture here to help each person personalize their dosing based on their symptoms. And if we can combine metabolics with hormones into our protocols, peptides and exosomes and hormones and all of these things, we'll have a much more robust blend for people who are truly trying to hack aging and live as long as they can. So if you're interested in getting started with hormone therapy and you're not really sure how or where, you really want to see a specialist. You want to see a practitioner that's trained in hormone therapy, and not just regular hormones, but bioidentical hormones. And you want to make sure they're doing a comprehensive evaluation, whether it's blood, saliva, urine. I'm not a huge fan of urine because we're looking at the metabolites. We're looking at things that are spilled out in our urine. We're not really looking at what's happening on a day-to-day basis. But there is a positive on the urine test, is we can see how your body metabolizes these hormones. And so if you have a pathway that's blocked from a genetic piece that we don't know about, on the urine test, we can actually see if your body's going to allow you to eliminate that estrogen or progesterone down the proper pathway. And if it doesn't happen, then we can give you different herbs, or sometimes we need to give medication to allow that to happen so you can safely use hormones. So that's where the urine test, in my opinion, is really important. Or if there's a high risk for breast cancer, there is a test that we can do that looks at all the estrogen metabolites, which can tell us, are we putting you at more risk or reducing your risk by balancing things? And then retesting is important. And you don't need to retest often because hormones take time to change. It takes 10 to 12 weeks before we see changes in hormone levels, whether we're testing urine, saliva, or blood. It takes the same amount of time. So initially, when you start on hormone therapy, you get your baseline, you start the hormone therapy, you retest again in about 12 weeks, and then you tweak it. And then I would recommend you retest again. But once you get the hormones balanced, you only really need to test twice a year to make sure everything is spot on. And some people, if you've been doing it a long enough time and we're not seeing any change, we'll just say, just test once a year because you're not changing anyway at that 6-month mark. So then we'll just test once a year. So that's my spiel for tonight. I hope you guys enjoyed that.